very good morning and welcome to Breakfast at UMHealth. I'm Jaya from the Endocrine Unit, Department of Medicine at UM, and it gives me great pleasure to chair and moderate the first half of the session, and after that, I will pass it on to Prof. Anusha. So the Endocrine Unit is very proud to introduce to you this morning's speaker, Associate Professor Dr. Ling. She's a very good friend and a colleague of mine. She's actually bred. She had her undergraduate done in University Malaya, went on to do a specialization in internal medicine and then endocrinology, and also successfully completed a PhD from Hong Kong. If you check out, she's very well published in the field of diabetes. Her areas of interest are actually in cardiometabolic as well as, of course, diabetes research. She's very interested in looking at translational research in terms of looking at how basic sciences could be translated to clinical care for patients living with diabetes. So she's also very well positioned to talk to you today. I'm sure you would have seen what the topic is about. It's about precision medicine in diabetes care. She actually sits on the board or the working group for the American Diabetes Association as well as the European Association for Study of Diabetes. These are big bodies who actually drive precision medicine. So there's a precision medicine initiative in these two big governing diabetes bodies. So this is actually the only global body, and we are very proud that Associate Professor Dr. Ling is part of that body. She actually also is a reviewer in multiple journals, and without further ado, I think I'll hand over the Zoom to her. And just to remind everyone, you can type in your questions not into the chat box, but rather into the Q&A function that you can find on the bottom of your Zoom app. So Associate Professor Dr. Ling, the Zoom is yours.
Thank you very much, Prof. Jaya, for the kind introduction. First of all, I would like to thank the Faculty of Medicine for the opportunity to share my thoughts in this Breakfast at UMHealth session. So my topic today is how do we drive precision medicine in diabetes care? I will start off with the definition and opportunities of precision medicine in diabetes, followed by a brief overview of how we can actually translate science to clinical values, and then I'll conclude my presentation. The practice of medicine centers on individuals. In the early years, the physician has actually started to ascertain patients' signs and symptoms. We recognize disease pattern and we tailor medical therapy that's best suited with the situations at hand. And in 2011, United States National Research Council defined precision medicine as the tailoring of medical treatment to the individual characteristics based on sub-classification of individuals into different populations due to variation in their disease susceptibility and treatment response. And this will benefit the best person and to prevent adverse effects. In 2015, President Barack Obama has launched the Precision Medicine Initiative, which has since then been renamed as the All of Us Research Program. Similar initiative has been conducted in the UK and Singapore. And in December last year, Academy of Science Malaysia has also released a position paper on how to move forward with the Precision Medicine Initiative in Malaysia. Building an information commons, including electronic health records, epigenomes, genomes, or even microbiomes data into an integrated knowledge network will modernize the way how we conduct clinical and biomedical research. This will enhance our understanding about fundamental biological processes, which can improve diagnostic accuracy for effective and targeted treatment, leading to improved health outcomes. And the increasing availability of genomics as well as the electronic health records data has even drawn a deeper consideration into precision medicine in diabetes. We have potential application to improve prediction and diagnosis of diabetes and the complications. Precision medicine can also help to predict treatment response. It's important for us to note that residual risk of diabetes-related complication remains despite medical treatment. But what could that be? Could this due to genetic predisposition, or because there are still unrecognized cardiometabolic risk factors and therefore not being treated? And this actually opens the era of precision medicine in diabetes. There are 5 pillars, namely precision diagnostic, prevention, treatment, monitoring, and prognostics. I will provide an overview of existing work on precision diagnostics. One problem that we face is diabetes is diagnosed based on non-specific endpoint, namely hyperglycemia. Using data from our 2019 National Diabetes Registry, 99% of patients were registered in the NDR were reported to have type 2 diabetes, even though it's pretty similar to the global trend, but the proportion will be slightly higher. Could this be due to misclassification or misdiagnosis? It's important for us to note that there are also other types of diabetes. It can be secondary causes, can be monogenic diabetes or maturity onset of diabetes of young, or even with the presence of latent autoimmune diabetes of adults or later. There's a lot of interest for refining diabetes subclassification in order to better predict disease cause. We can also to better predict related conditions, and this table shows some selected genes that have been associated with type 1 diabetes, which are also being reported to have significant association with other autoimmune conditions such as celiac disease, Addison's disease, and autoimmune thyroiditis. A better diabetes subclassification can also help us to predict risk of complications such as rapid kidney function decline as shown in this figure. When we're able to subclassify patients better, it can help to guide treatment decisions, whether with the current treatment regimen or even in the future, such as implementation of clinical trials, which involve the development and validation of novel therapeutic strategies and targets. There are two approaches for us to subclassify diabetes, either by using clinical data or genetic data. I'm sharing a landmark paper using 5 Scandinavian cohorts. It is the first paper to describe the phenotype-driven approach for diabetes subclassification. It involved discovery cohort of close to 9,000 patients with newly diagnosed diabetes. And in this discovery data set, 94% of the patients reported to have type 2 diabetes at enrollment. 5% of them had LADA, while 1% had type 1 diabetes. And the study group utilized 6 traits that were measured at enrollment at the diagnosis of diabetes, namely age of diabetes diagnosis, HbA1c, body mass index, a specific insulin antibody, the anti-GAT, and estimates of beta cell function using C-peptide, HOMA-beta, and HOMA insulin resistance. And what do you see? They actually identified 5 different clusters of diabetes. And these 5 clusters vary by disease cause and risk of complications. If you look on your left-hand panel, cluster 1, which is severe autoimmune diabetes, SADE, and cluster 2, with a severe insulin deficiency diabetes, SID, were more likely to require insulin early in the course of disease compared to the remaining 3 clusters. And cluster 3, which is renamed as a severe insulin-resistant diabetes, was more likely to develop chronic kidney disease and coronary artery disease compared to other clusters. If you look at the old term, SIRD, severe insulin-resistant diabetes, would be pretty reflective of type 2 diabetes that we're using currently. And for SADE, the cluster 1 will be type 1 diabetes, while SID, the cluster 2, will be LADA group of patients. And this phenotype-driven approach has been validated in 6 other populations in the US, other European countries, and in Asia. And interestingly, in the Indian population, they actually added as extra traits in the analysis. Apart from the 6 existing ones, which I've described just now, they actually included waist circumference, triglyceride, and HDL cholesterol in the cluster analysis. And they actually identified 2 additional clusters, namely IROD, will be insulin-resistant obese diabetes. This is pretty similar to the phenotypic heterogeneity in South Asians. And the other new cluster would be combined insulin-resistant deficient diabetes, where this group of people tend to present with difficult to control hyperglycemia, as well as microvascular complications such as chronic kidney disease and diabetic retinopathy. And the motivation for precision medicine in type 2 diabetes mainly comes from monogenic diabetes. Monogenic diabetes actually evolved from a single gene mutation, for example, either GCK or HNF mutations. It tend to implicate a specific pathway to the disease pathogenesis, and there's a specific treatment strategy. But we look at the other end of the spectrum. Type 2 diabetes mainly arise from common genetic variants with a minor allele frequency of more than 5%. And to date, multiple genome-wide association studies have led to the discovery of more than 240 genetic loci, amounting to around 1,000 genetic variants with genome-wide significance level. And this explains up to 20% of the type 2 diabetes heritability. And there's also increasing interest of trying to include all these significant genetic loci into polygenic risk score, and we try to partition them based on pathways. Cluster analysis have been performed for this significant genetic variants. It would be the genome-wide significance level versus multiple cardiometabolic traits, where the effect sizes were derived from publicly available GWAS summary statistics. And they identified 5 distinct mechanistic pathways. 2 were related to insulin deficiency, while 3 on your right would be related to insulin resistance. And the top 3 genetic loci that be associated with each pathway are actually listed here. If you look at the spider plot, these 2 clusters will be insulin deficiency clusters, and they differ by the level of pro-insulin level, high in the beta cell cluster, while will be low in the pro-insulin cluster. In the obesity-mediated cluster, you may notice there will be high BMI and waist circumference, while in the lipodystrophy cluster, mainly related to fat distribution, you'll see a high triglyceride level, but with a low BMI waist circumference and low level of HDL cholesterol. In the last cluster, mainly related to abnormal liver and lipid metabolism, there will be a low triglyceride level. And these 5 clusters have been reported to have significant association with certain types of clinical outcomes. This derived from the people with type 2 diabetes from the CHART Consortium and UK Biobank. There will be increased risks of coronary artery disease and ischemic stroke, as well as a higher blood pressure level, and with special types of kidney function parameters we tend to use in clinical practice, will be namely estimated glomerular filtration rate, as well as albuminuria status. Next, I'll try to provide a brief overview of existing work on precision prognostics. We won't have time to cover the entire 5 pillars, but I just provide some of the brief overview of the significant work for the translation from science to clinical value. Using the Hong Kong Diabetes Register as an example, over the median follow-up 13 years, they actually looked into the trajectories of the estimated glomerular filtration rate of 6,300 patients with type 2 diabetes who were free of chronic kidney disease or proteinuria. You will be able to appreciate that close to 85% of patients with type 2 diabetes experience gradual eGFR decline over a period of 13 years. However, there's also a significant proportion at 3% who experience accelerated decline in kidney function, and they would likely progress to end-stage kidney disease either rapidly compared to other phenotypes. There were also intermediate phenotypes, whether patients with progressive decline or curvilinear decline at 6% respectively. But given that we now have effective therapies trying to slow the disease progression of diabetic kidney disease, one would argue that we should identify this group of high-risk individuals who are more prone to develop accelerated decline in kidney function. This group of people would warrant early intervention to prevent further disease progression. However, the genetic basis for rapid kidney function decline has remained largely unknown until this meta-analysis of 42 genome-wide association studies from the CKD Genetic Consortium and UK Biobank. There were 2 definitions of kidney function decline used in this analysis, either RAPID-3 or CKD-25. And RAPID-3 was defined having an annual eGFR decline of more than 3 mL per minute, while the CKD-25 definition were actually based on these having an eGFR decline more than 25%, as well as having an eGFR level of lower than 60 mL per minute during follow-up. 5 genetic variants from 4 genetic loci achieve genome-wide significance level as shown here. There's also another effort trying to use plasma biomarkers for improved prediction of rapid kidney function decline in type 2 diabetes population. And this figure shows the results of a multinational ProValid cohort. At enrollment, they managed to recruit close to 2,400 patients with type 2 diabetes, in which 500 of them had measurements of plasma biomarkers at baseline, and actually tried to compare the plasma biomarker level among patients who were fast progressors and those patients with stable kidney function. And 5 out of these 17 plasma biomarkers have shown significant association with rapid kidney function decline in type 2 diabetes population. And they accounted to close to 30% explanation of the variability in eGFR decline in this study population multinational cohort. Another idea would be gene-environmental interaction, because people can differ genetically in terms of the response to the effects of the environmental risk factors on cardiometabolic traits. If you look at this figure, which shows an example of the interaction of some biallelic genetic variants and then environmental risk factors. And gene-environmental interactions will actually reflect that the genetic effects tend to differ in magnitude across the different levels of exposures of the environmental risk factors. And using data from UK Biobank as an example, where they have close to 90,000 of people with available genotyping data. And this table summarizes the percentage of change in body mass index per copy of the FTO risk increasing allele and per standard deviation of the environmental risk factors. I've shown here the results for certain types of environmental risk factors, namely the physical activity level, the dietary patterns, as well as the sleep duration. And the overall interpretation would be among FTO risk carriers, when there's an increased level of physical activity would help to reduce the risk of obesity. On the other hand, when there's a poorer dietary pattern with the high salt diet, or even with the increased deviation from the mean sleep duration, would have increased the risk of obesity. So in summary, there's abundance of clinical data which support that early diagnosis, prevention, and intensive treatment can exert beneficial impact on diabetes outcome. But what is the role of precision medicine in diabetes care nowadays? The implementation of precision medicine can expand our understanding of disease pathogenesis by integrating clinical data, genetics, omics signatures, including metabolome, proteome, or even microbiome, but we also need to take into account the significance of gene-environmental interactions on this polygenic disease. And this integrated disease knowledge network would help the development of novel therapeutic strategies and targets. However, we need to bear in mind that their clinical utility will need to be proven before broad implementation in clinical practice. And this figure shows the roadmap for successful implementation of precision medicine in diabetes as recommended by the American Diabetes Association and the European Association for the Study of Diabetes. We shall start by conducting clinical and biomedical research, trying to understand the disease trajectories, the clinical epidemiology of diabetes. We should identify specific biomarkers for improved diagnostic, treatment, and monitoring. And we should also try to integrate selected biomarkers into existing risk algorithm and see whether this could actually improve disease prognostication. It is good to engage patients and the public early in the course of research to gather feedback, and clinicians will also need to be well equipped with the relevant skills and knowledge for better clinical translation. And to meet this objective, we are currently building infrastructure for recruitment of the diabetes cohort, for collection of health data and banking of biosamples, for launching of the relevant diabetes research. And we hope that we're able to provide more results in the near future. Last but not least, I would like to thank the ADA and EASD for the opportunity to participate in the Precision Prognostic and Type 2 Diabetes Work Group. I will also need to thank my current work group members, as shown here, who have provided important clinical insights on our ongoing work in Malaysia. Thank you for your kind intention and welcome any comments. Over to you, Jaya.
Thank you very much, Ling. That was very enlightening. And I'm sure you'll all agree that she has really opened the doors to the future. So Ling, can I start off by asking you, I know you showed us the roadmap in terms of implementation or even getting to some sort of precision medicine for polygenic diabetes. How far away is this roadmap? I mean, will I ever see it before I retire? Will you retire before that? Or, I mean, it seems very labor intense.
Yes, Jaya, you're correct. It's not a 1 to 2 years work. I believe that it may take around 5 or even up to 10 years in order to see the actual results. But if you look at the roadmap as recommended by ADA and AASD, they have actually launched, I didn't show the figure, but they have shown that there's a very, very huge ambition from ADA and AASD. They have divided the effort into 4 different phases. They've launched the phase 1, where the consensus report trying to increase awareness among the researchers as special clinicians about the importance of looking into precision medicine in diabetes nowadays. We are currently in phase 2. We're trying to do some additional work to support the recommendations by these 2 strong bodies. And the entire roadmap for 4 phases, we aim to have the actual, to complete these 4 phases by 2025.
Okay, that's actually faster than I thought. I thought it would actually take longer than that. Yeah, so can I ask you, Ling, what are because it seems, I mean, for someone who's not familiar with precision medicine, I mean, it seems quite complicated. I know you showed us from, I mean, in terms of epidemiology, in terms of diagnostics, prognostication, and as well as treatment. What are the barriers that you think we would face, I mean, in Malaysia or in itself?
I mean, the first thing, the infrastructure is not only of the hardcore facilities, because we do have biobanks, lab called Honey, and lab support is very important. Manpower, we need basic scientists who are well trained in genetics, as well as multi-omics analysis. We need help from bioinformatics experts. And all this will come back to one single word, will be the dollar sign.
Yeah, so I mean, how far are we? I mean, in itself, FOM, I mean, in terms of this multi-omics, have we started, or, you know, in terms of collaboration or?
Yeah, I mean, we have a project underway. Trying, hopefully we will actually hear good news from the funding agency, and we can actually try to kickstart. We do have a few experts in the Faculty of Medicine who also look into the molecular genetics as well as the metabolomics.
Okay, I'm going to ask you a question. Somebody has asked, he's probably an anesthesiologist as well. He or she is actually asking, how would all this precision medicine in diabetes affect other specialties? I mean, for us in diabetes, yeah, I mean, probably we're going to adjust treatment and we know about prognosis and which patients develop what complications. But for other specialties, how do they implement precision medicine in diabetes?
The main thing that if we include both genetics and other lab molecular markers into us, we will be able to risk stratify patients. We're able to pinpoint whether this patient A versus patient B, who will most likely develop complications, either acute or chronic. Again, it depends on the amount of data that we have and what kind of integrated analysis that we actually provide. So I believe that it actually benefit not only endocrinologists or diabetologists, and once this actually up and go, we were able to know which patients would be more susceptible to the development of diabetes or even development of complications related to diabetes.
So going back to dollars and science, I think, Ling, I have to bring this up again. I mean, you showed us that precision medicine is probably the way to go. I mean, oncology, I think, is in the forefront for that, isn't it? Compared to all other specialties in medicine. I mean, and diabetes is following as well behind. But I mean, looking at the amount of work that's need to be put in, and for every patient to achieve that sort of precision, is that actually going to incur more cost? I mean, what is the cost benefit ratio for this in the end? I mean, or should we just keep to standard practice, which is what we are doing now, which is, you know, metformin, sulfonylurea, or, you know, SGLT2s, you know, that sort of thing? I mean, is it actually going to be cost effective in the end, precision medicine?
It would, because again, it's back to the volume. The Academy of Science Malaysia, the position paper on precision medicine initiative, which include both diabetes, the entire spectrum of disease, they have shown a pretty nice graph also together with the US NIH data that when we have increasing volume, the cost for all this genome sequencing will actually reduce considerably, reduce significantly. So of course, at the beginning stage, we may face that all this would be quite costly. But if the uptake is good, of course, prior to the increased uptake, we need to prove that this is really useful in addition to what we are practicing right now. Okay.
So I suppose the good examples are like with monogenic diabetes, which they have shown that, genetic studies are the way to go and precisely treat patients, isn't it? And even
Yes.
in oncology patients, in which they do specific mutations for certain cancers, and they know which drug or which inhibitor to exactly give the patient.
Yes,
Yeah.
because cancers and monogenic diabetes, they are mainly on single gene mutation. So it'd be even easier for them to prioritize treatment. But then for diabetes and other cardiometabolic traits, because they tend to be polygenic, so therefore we're actually shifting from looking into candidate gene, but towards looking into polygenic risk score. We take into account a number of the genetic loci, genetic variants, and try to look into, because we actually look into patient a holistic approach. We don't say that, okay, I just want to sequence just one gene for polygenic diabetes. It won't work.
Sure. Yeah, I get that. So, I know you showed some data from Hong Kong regarding the renal complications, and probably there is some with cardiovascular complications. Are there any precision medicine data with other, like maybe retinopathy? Some ophthalmologists might be interested in that. In terms of who will progress into what sort of diabetic retinopathy, or who will get maculopathy. Is there any data on that?
Yes. I've discussed about two studies just now in the presentation. One would be using the Scandinavian cohort led by Professor Leif Group. So the type 1 diabetes related trait, whereas I've shown 5 different clusters there. So for the state, the cluster 1, severe autoimmune diabetes, and also cluster 2, the severe insulin deficiency diabetes, the SAID and SEED, they're actually more prone to develop retinopathy. And this is also being replicated in the Indian population. And they found that the additional cluster in the Indian population, the combined insulin-resistant and deficient diabetes, they're actually more prone to develop diabetic retinopathy. So they're actually looking into the genetic studies, trying to identify specific variants. And we of course, we will need to look into that in the near future.
So will we be looking at that as well? In our Malaysian cohort as well?
We can try, because we need to recruit help from the ophthalmologists, because it involves procedural diagnostic codings, and then how are we going to capture the disease correctly in order to have a better categorization of the diabetic retinopathy.
Yeah. I know you mentioned electronic medical records, and I think I'm so happy that UMMC has progressed to that in the last, I think, 5 or 6 years or so. Would all of this be possible without electronic medical records? Capturing data for precision medicine, or do you think it would have been impossible if we still had written papers?
Yeah, Jay, I agree with you. We are actually quite fortunate because UMMC has rolled out the EMR since 2013, I believe, or so. So if without EMR, I don't think we'll be able to make precision medicine into reality.
Yeah, okay. There's also a question about prevention. How can we use precision medicine for prevention of diabetes? So before you even get diabetes and talk about treatment and complications, can we go one step back and talk about prevention? Is there any data of precision for prevention?
Yes, there are actually 5 pillars of precision medicine in diabetes. I'm sorry I didn't manage to go through every, so I've just handpicked 2 out of the 5 pillars to be discussed in this webinar. So we do have precision prevention arm, and this is to prevent people from getting diabetes. It's also very relevant in the Malaysian populations because our obesity rate is high, and we're also seeing younger population developing diabetes. So one good example would be the US Diabetes Prevention Study. they actually look into the pre-diabetes group and actually try to intervene with the lifestyle, a specific lifestyle program. They also look into the genotyping data and realize that patients who actually had a higher genetic predisposition to diabetes and or obesity, and this group of people, the response toward a similar implementation of lifestyle program would have reported a higher amount of body weight loss and therefore remain to be in remission compared to those with a lower genetic risk. So right now, the concept would be we try to risk stratify. Because of limited resources, we should either handpick those who are actually high risk and intervene early, either for prevention or treatment to prevent complications.
Yeah, so maybe I can just reinforce that again. Maybe you can reinforce that again. So at the moment, in terms of precision medicine, are there certain patients in which you would sort of advocate to be more precise in terms of how you would prognosticate or treat them? I mean, at the moment in 2021, are there any clinical indicators that we can use and decide, oh, this is someone that we should actually be a bit more precise in terms of treatment? Because actually to project and to go ahead 10 years ahead of time, I think is a bit quite aspirational, quite ambitious. But what do we do now?
So at present, we still rely on our clinical acumen as well as what we're practicing in clinical settings. So young onset diabetes, or even we're particularly interested in young onset diabetes. Why are they developing complications when additional risk factors would be those with a strong family history of diabetes or premature coronary artery disease? The additional standpoint would be if a patient having poorly controlled diabetes or together with other cardiometabolic risk factors like high blood pressure, high cholesterol, having high waistline, abdominal obesity. In terms of lab parameters, we also try to track. We look into the rate of eGFR decline. In general, the definition would be more than 3 mL per minute, as discussed in the presentations. And we look into that. We also work with our nephrology colleague, trying to see how are we going. First, of course, establish the diagnosis is really diabetes related. Sometimes some patients actually have non-diabetic kidney disease, and this would be a totally different treatment strategy. But if let's say it's a confirmed to be diabetic kidney disease, and we currently do have effective therapies trying to reduce and delay the progression of disease.
So I think you very nicely put it. I mean, definitely it's not a one-man show. There's no way we can do it ourselves, isn't it? We need to collaborate with everybody else in all the other specialties. So I think in the interest of time, I think the first session will have to stop here. I want to thank the organizers and thank you very much, Prof. Ling, for a wonderful presentation. And I think we've had a very fruitful discussion, opening the doors to the future in terms of precision medicine for diabetes. So without further ado, I will hand over to Prof. Anusha to moderate the next session with Dr. Ng. Thank you.
Thank you, Jaya.